All right, here we go. Kind of a short lecture. And I think from talking to some of you, I think you've had some of this stuff before, so it shouldn't be that bad. Let's see. That's like kind of loud. Oh well. There's our bird for the day. I got that one on Saturday. This is really a weird story. That's a belted kingfisher. All right, we're starting the heart today. So that's the heart. We have one heart in our body. Is it on the right or the left or in the middle? Where's your heart? It's in the middle, but just a little bit to the left. We'll show you exactly in a minute. It fits in the palm of your hand like this is a real human heart here. They classically say it's about the size of your fist. Quite an amazing organ. Of course, it pumps blood to every nook and cranny of the body, and it pumps through 60,000 miles of blood vessels you have in your body, so it's a lot. It has a lot of work to do. Kind of some more fun facts from the CDC about this heart. The average for people our age is about 80 beats per minute. It is, for babies, it's much smaller. It's over 100 beats. That should be 100 there. That's my voice recognition software blotting something in there. If you ever see weird words like that, that's where they come from. It is the leading cause of death in humans. It's been that way since the 1950s, and heart disease is a real problem. In fact, from the CDC, one person dies every 34 seconds from heart disease in the U.S. So it is a problem especially for older people. The risk factor for having problems with your heart are the usual suspects: atherosclerosis, hypertension, diabetes, smoking, obesity, and lack of exercise. Compared to people dying from COVID-19, way more people, twice as many people die compared to COVID-19. In 2020, a lot of people died from COVID, but still twice as many people died from heart disease. Some more fun facts about it. So how much blood is ejected each time? So every beat of your heart, about a quart of blood is ejected from the heart. Now that's pretty amazing. Specifically 1,000 milliliters, which is about a quart. The heart pumps about 3 billion times during your lifetime, 35 million times per year, 100,000 times per day. Am I going to ask you these numbers on the test? No. No, these are just kind of fun facts. There's no stars there, so just to give you an idea, the heart is actually very amazing. Where exactly is it found? Here's a pretty good representation of it. This might be a little bit big for the picture, but it is slightly off to the left, and it lives between the second intercostal space and the fifth intercostal space. It's covered by the sternum, and it's covered by costal cartilage of the ribs here. And a more exact location, we talked about this for the esophagus, so we can bring this back. So this is the mediastinum. Remember how this thing works? There's two divisions, and this is how you divvy up your chest. There's two divisions. There's an upper or superior mediastinum, and then there's a lower inferior mediastinum. And this demarcation zone, we said, is if you take a stick and you push it right through the sternal angle of Louis, horizontal to the ground, that'll go through the L4 or the T4 disc. That is the dividing point. So anything above that line is superior mediastinum, and anything below that line is inferior mediastinum. So the inferior mediastinum is split up into three parts, and the middle part of the inferior mediastinum is the heart and the pericardial sac. That defines it. So anything anterior to the heart is the anterior portion of the inferior mediastinum. Anything posterior to the heart is the posterior portion of the inferior mediastinum. The superior mediastinum is not split up like that. There's only one superior mediastinum. In this little line where I said push a stick through the sternal angle, that actually has a name. It's called the thoracic plane. The thoracic plane. or it's the plane of Ludwig is another term for that. And again, it goes through the sternal angle of Louis. We'll look at the sternum here in a second, and it goes right through the inferior end plate, or you could say the T4 disc is where it goes. So everything we kind of said already. Here is the sternum. You should have studied this in spinal anatomy. Have you guys looked at the sternum yet? Great, so you know all this stuff. But here's the sternal angle of Louis. It's also called the manubriosternal joint. And it doesn't really move much. It's like the symphysis pubis. It's in a joint, but it doesn't really move normally. And of course, this is the manubrium. This is the body of the sternum. This is the xiphoid process. And the meeting between the manubrium and the body of the sternum, that's where this manubriosternal joint comes in. So you should know that. Did you know what these things are called? What are these segments called? They're called sternebrae. There's actually a name for them, sternebrae. Because they're kind of vertebrae, embryologically speaking, they're kind of akin to that, so they call them sternebrae. Another really good board question, they always like to ask, what full ribs connect to the body of the sternum? And so that's rib 3, 4, 5, and 6. And does the rib actually connect to the sternum? Or is it the costal cartilage? It's the costal cartilage that actually makes the connection. So you should know that. That is one number you should know. Ribs 3, 4, 5, and 6, they fully connect to the body of the sternum. Rib number 1 is the one that, I didn't put that in there, but rib number 1 is the one that fully connects to the manubrium. So you should know that as well. Not for me, but for boards. This notch up here, we said that's the jugular notch. We can all feel that thing really easy. If you just come down, slide down from your Adam's apple, and you'll feel it right there. If you do a peace sign, you should be right on the sternal angle of Louis. If you roll that bottom finger, some of you will feel a pretty good lump or ridge right there. And that's the sternal angle. That's how you find, in palpation, that's how you find your second rib. Peace sign, find the sternal angle, and slide laterally and roll your finger around, and you'll feel a nice rib right there. And sometimes they're a little tender there, but that's the second rib. Okay, I think we got all that. What's its main job? Again, we said it pumps blood to every nook and cranny of the body. Is a very cool picture of the heart showing the major blood vessels. And let's not forget that the heart pumps oxygenated blood to the lungs through the bronchial vessels, and it pumps blood to itself. What's the name of the blood vessels that carry oxygenated blood to the heart? Coronary arteries, coronary system. So it does supply the lungs and the heart as well. It's kind of weird. The heart pumps blood everywhere in the body, and it actually has blood vessels going to itself at all. So far, you guys probably know all this stuff. Now I think a lot of you probably won't know this, so let's learn some new stuff maybe. The muscle cells of the heart, they actually are considered endocrine cells. They do have the ability to release 2 hormones. One is called atrial natriuretic peptide, or ANP. Sometimes it's called ANF for factor. And the other one is called brain natriuretic peptide. And has anybody heard of those before? Are those kind of new to you? These are the ones, well, you've heard of angiotensin 2 for sure, or maybe not. Yeah, we talked about angiotensin 2. Angiotensin 2 brings down or brings up your blood pressure. If you're bleeding, I think we used the example, if you're cut and bleeding, the R2A system turns on, releases angiotensin 2, and it rises your blood pressure up. But we didn't talk about what can bring your blood pressure down. And it's actually these natriuretic peptides. There's 3 of them, too. There's another one. There's a CNP that we won't talk about. Because that one doesn't come from the heart. But atrial, guess where that comes from? The atria, the endocardial cells They're just like endothelial cells, I always want to say, but there's a single layer of cells that line the heart, and they're able to secrete ANP. If the blood pressure gets up high enough, they automatically sense that and release this ANP, and it brings the blood pressure down. Same with BNP. I don't know why they didn't call this VNP, ventricular natriuretic peptide. Would be nice, because that's the cells that secrete BNP. And the reason when they first studied it, and I think it was a sheep, they thought it came from the brain, and they were mistaken, but the word stuck. It actually comes from the ventricles of the heart, but that word kind of stuck. Like thoracic outlet syndrome kind of stuck, even though it's really should be thoracic inlet syndrome. Okay, so these guys, they lower blood pressure. How exactly do they lower blood pressure? Well, one way to lower blood pressure real quickly is to kick sodium out of your body, out of your bloodstream, out of the interstitium. So we all have a bunch of sodium floating around in our blood right now. When it passes through the kidneys, most of it's usually reabsorbed. But if you want to get rid of water from your body, just kick sodium out. And that's exactly what both of these, ANP and BNP, they do. They stimulate the kidney to dump sodium. You could say salt as well, because chloride goes as well. But if you dump sodium into the urine, who always follows sodium like a puppy dog? Water. And so if you dump sodium into the urine, water will follow. And if you take water out of your blood, what's going to happen to your blood pressure? It's going to drop down. And that's the mechanism right there. Okay. Let's see. And water follows. That's everything I said right there. So it causes hypotension, so it lowers your blood pressure. Oops. Does some other things too. If we lose sodium out of the blood more than we're supposed to, you get a condition called low blood sodium, and that has a word, of course. Hypo means low, and then natremia, that means sodium. That N-A-T-R-E is sodium. So hyponatremia means you don't have enough sodium in your blood. Where did the sodium go? It got kicked out in the nephron. It got kicked out in the kidney, went into the urine, because of ANP and BNP were binding to we'll just say the nephron for now. We won't get any further into the weeds than that. If blood leaves the water, it causes hypotension, but it also decreases the volume of your blood. So you also have hypovolemia, which means that you just don't have enough H2O molecules floating around in your bloodstream. That will automatically, these two always go together. If you don't have a lot of water in your blood, you're going to have hypotension right there. Okay, so make sure, that's a good testing question, right? 3 things right there I could say. So make sure you know the effects of ANP and BNP, or the natriuretics, you could say collectively. Everybody good with that? Pretty straightforward question.
So is volemic shock, is that related to hypovolemia?
Hypovolemic shock is when your blood pressure is so low that you're not properly perfusing the brain and the organs. And that's what shock is. Shock it depends what type it is. But hypovolemic shock will cause hypotension, meaning you don't have enough pressure to send blood up to the brain and you're really in a state of passing out. I think I actually have slides on shock coming up though. We talk about a cardiogenic shock. You should know what the process of diuresis is, in case you don't already. So we've heard of diuretics. Wrestlers are known to take those things to drop a bunch of weight before a match. They basically kick water out of the blood. And diuresis is the same thing. It's the process of excreting water from the kidneys into the urine. It's stealing water out of the body, mainly from the blood, and it's kicking out of the body. Diuresis can do these same things. Diuresis can cause hypotension. We can understand that. If you lose water, your blood pressure is going to drop. That's hypovolemia as well. If you lose water, your volume of blood's going to go down. But how about this one? If you take diuretics, you have to be very careful that this doesn't happen. Hypernatremia. So what's hyper mean? Too much. And natremia is sodium. So this is too much sodium in the blood. The body does not like that at all. All kinds of things can go wrong with you. But how would this happen? Why would you become hypernatremic if you take a diuretic? It kicks out sodium, or it kicks out water, but leaves behind sodium. I said some water follows. When you kick out sodium into the urine, it's not a perfect ratio. Not as much water follows as sodium. So you will have a buildup of sodium in the blood if you lose too much water. Same thing. If you lose too much water through the nephron, some sodium will follow it, but more will be left behind. We have some conditions with the adrenal gland that can cause adrenal insufficiency and things like that, which you'll get in endocrinology. But for now, hypernatremia means there's too much salt in the blood, and people who take diuretics, they lose water, but it's not a perfect ratio. They take too many sodium molecules and not enough water follows, so they're left with too much water in the body compared to sodium. All right, here's ANP and BNP again. Everything I said, they're released from the endocardial cells. BNP is brain natriuretic peptide. ANP is atrial natriuretic peptide. And these both stimulate the kidney to suck sodium out of the filtrate, or kick sodium out of the blood and push it in the filtrate and push it down into the toilet. So the body loses sodium. The decrease in sodium and some water causes the decrease in blood pressure, and both of these are responses to hypertension. And they're good mechanisms. They're a way to fight hypertension. They're not super powerful because so many people have hypertension. Even though these mechanisms are on, they can't. Most types of hypertension can't be overcome by this mechanism. It kind of loses its power after it's been turned on for a while. But in a short term, it works pretty good. How does blood travel through the body? I think we talked about this already, but let's throw these back up. So here's our heart right here. And there's two loops or two circuits, you can call them. We have a short one going to the lungs and back. That's a really easy one. That's called the pulmonary loop. Very easy job to pump blood just through the lungs and back. And then the tough one is the systemic loop. That loop goes to every nook and cranny in the body. And yeah, there it is, the head, the digestive tract, the kidneys, the little toe. Everywhere else except the lungs is the systemic loop. And there it is going right up. There's where it comes out, the ascending aorta and the aortic arch. This is just a simple cartoon, but you get the point. So systemic, pulmonary loop, those are the two loops. So therefore, if there's two loops, there must be kind of two sides to the heart of ours. And there are two sides. So we have a right side of the heart and a left side of the heart. So the right side of the heart is the one that pushes blood through this pipe right here. We'll look at this more in a second. And that goes to the lungs. Let's back up and look at this cartoon. So there's the pulmonary trunk. This is the right side of the heart, right atrium, right ventricle. Blood goes up through here, goes to the lungs, comes back to the left atrium, or atrium. Okay, pretty easy job. So if you dissected a heart, and when you look at those in lab, I think, is that next quarter or maybe the quarter after that, you will be tested on this heart. What do you think the walls of this right heart are going to look like? Are they going to be super stiff and muscular, or are they going to be kind of wimpy? They're kind of wimpy because it has such an easy job. It's so easy for the right heart, has it so easy. When you look at the left heart, that's got to pump blood through that systemic loop, much more powerful. Everything's bigger. The interventricular septum is huge. The walls are huge. Everything's bigger because it's a much more powerful muscle than this right side of the heart. Okay, so right heart. So when I say right heart, it's understood that I'm talking about the right atrium and right ventricle. When I say left heart, it's understood that I'm talking about the left atrium and left ventricle. Okay, what's under the hood? So let's cut this heart open and see, and you probably have had this a million times, but we have our heart is made of 4 chambers. The top 2 chambers are called atria, is plural. Atrium is singular, so there's a right and left atria. And the more powerful part of the heart, those are the ventricles, and there's a right and left ventricle. Okay, pretty simple so far. Now there's valves that are very important because these chambers, as we'll see, they have to be able to seal off from each other. So we have some valves that will isolate each one of these chambers. So going from the right to the left, the saying is try before you buy. So tricuspid's on the right side, bicuspid's on the left side. Okay, so tricuspid valve, it separates the right atrium from the right ventricle. The bicuspid valve, what's the AKA for that? Mitral valve. And when you get in pathology, you never say bicuspid, never. It's always mitral valve out of respect for this valve. This valve kills people if this gets messed up. So I always say mitral valve. So that separates the left atrium from the left ventricle. If you want to talk about both of these valves in one word, they're called the atrioventricular valves. Why would it be atrioventricular valves? Because the atria and ventricle, atrioventricular. It means it's in between the atria and the ventricles. Okay, and now let's look at the other ones. Where'd the other ones go? Oh, I guess they're on the same slide. So then we have the semilunar valves. Specifically, did I mess this up? No, semilunar valves, that's right. Oh, I did mess that up. That's got to be down here. Okay, I got to fix that. Semilunar valves are the aortic valve and the pulmonic valve. So let's take a look at them. So when you see the heart in the anatomy lab, it's not going to look like this little simple model. The right atrium is actually pushed posterior, and this is more out of the plane of the page because this pulmonary trunk is over the top of the ascending aorta here. So this is a very superficial structure, but the pulmonic valve or the pulmonary valve is right here. The aortic valve is a little harder to see. It's actually deep to this. It's underneath here. So that's the aortic valve. This is a big problem that humans have, is a regurgitation of this aortic valve or a stenosis of the aortic valve. They say that having a problem with the aortic valve is as bad as having cancer. It's a really bad diagnosis because you can try to fix it, but sometimes it doesn't work so good. And aortic stenosis, it's a tough operation. And it's a fairly common problem. But there's the aortic valve and there's the pulmonic valve or pulmonary valve. Together, those are called the semilunar valves. Okay? The AV valves are the try before you buy, tricuspid, bicuspid, and mitral valve. Are we good with that so far? Pretty simple? Now the concept of the great vessels. You may have heard that word before, great vessels. Who are the great vessels? I do expect you to know the great vessels. So the great vessels are the ones that actually connect directly to the heart itself. So all we need to do is look at them. So there's 2 that connect to the right atrium. There's a superior vena cava and there's an inferior vena cava. So those are members of the great vessels just a side note, some authors don't include the inferior vena cava as a great vessel because the pericardium that goes around here doesn't really enclose the inferior vena cava that well. For chiropractors and for your boards, they are members of the great vessels, but there is a little controversy about that inferior vena cava. What else connects to the heart? What other major pipes? Well, here's the one that takes the blood away, deoxygenated blood. So that's the pulmonary trunk right here. I've heard this called just the pulmonary artery before in pathology books because it splits into a right and left pulmonary artery. And what type of blood did we say is in here? Is it oxygenated or deoxygenated? It's deoxygenated. And why is it called an artery then? It's going away from the heart. Any vessel going away from the heart is called an artery, whether it has oxygenated blood in it or not. Okay. Then we have this one that's hard to see, but it's oh so important. It's this ascending aorta right here. Okay, that's another one of the great vessels. That immediately turns into an aortic arch right when it hits this first takeoff. Anybody know what that first takeoff is? Brachiocephalic trunk, which is going to split into a common carotid artery and subclavian artery. But I don't expect you to know these, but that's where it goes. I do expect you to know who the great vessels are, though, for sure. And then we have one more great vessel, and this one's really 4 vessels. So these are heading back. These are pulmonary veins. Oxygenated or deoxygenated blood? Oxygenated blood. These are fresh coming back from the lungs. Okay, let's look at blood flow through the right heart. Pretty easy. So it comes in through the vena cavas, superior and inferior vena cavas. Is there a valve here between the superior vena cava and the right atrium? Valve or no valve? No valve. That's why, have you ever laid down or been looking at someone and they're laying down, you can see a pulsation kind of out by the SCM? That's the jugular, the external jugular vein, and the reason it pulses is because you get a backwash on every heartbeat, a little wave going back through the superior vena cava, and that splits eventually into an external jugular vein, and so you get a little wave, a little pressure wave going up there. Got to make sure that's not too big sometimes, and you'll learn about Kussmaul's sign, where these can bug way, way out in people with heart failure. But there's no real valves, no functioning valves here. So blood comes into the right atrium. It goes through these, what are these called, these valves? Tricuspid. You could call it, I guess, you could call it the right AV valve or right atrioventricular valve. You shouldn't do that, but I guess you could. It's better to call it tricuspid valve. And that's in pathology, that word holds all the way through pathology. Then the blood gets into the right atrium, and then it goes out. What's this valve called? Pulmonary valve or pulmonic valve. I guess you could call it right semilunar valve, but you shouldn't really do that because it's in pathology it's always the pulmonic or pulmonary valve. It goes up this pipe, we said is the pulmonary trunk. Just thought of another. Sometimes they call this the innominate artery. Some other texts, I've seen that AKA, but that won't be on boards for you guys. And then this splits into a right and left pulmonary artery here. So that's the blood flow through the heart, through the right side of the heart. Now how about blood? Let's keep following it. A little different model here, but here's the pulmonary trunk still. And there's the pulmonary arteries. So we got our deoxygenated blood heading to these big circles, and of course this is not what the lungs really look like, but in this little cartoon I created, that is called, we can just call that the alveoli, because the alveoli, which are everywhere in the lungs, they do this scenario right now. They're doing it. They take deoxygenated blood and they put oxygen on the blood. They take, what do they take off? They kick CO2. CO2 gets to the boot. You breathe out CO2 in exchange for oxygen. And so the oxygen comes back through arteries or veins? Pulmonary veins, and they dump into the left atrium right here. Okay, so CO2 is removed, oxygen was added, and it's really the red blood cell that does this stuff. And if you want to go deeper, it's the hemoglobin molecule that will carry the oxygen. You probably learned that in biochemistry, or you will very shortly. Hemoglobin is really important. We won't go that deep into this though. Okay. Okay, so we already said this. So pulmonary veins bring back the oxygenated blood, gets dumped into the left atrium here. And then what's this valve called? Try before you buy. So it must be the bicuspid or mitral valve. Goes through that, gets into the powerful, mighty left ventricle, most important muscle in your body right here, this left ventricle. And blood gets shot up the ascending aorta here. It goes underneath the pulmonary trunk. It goes through these very important valves. What were those called? Aortic valves, just like aorta here, ascending aorta, aortic valves. And then it's off to the races to every nook and cranny of your body. There's actually there's two little arteries that come right off here. This root of the ascending aorta, those are the coronary arteries, right and left coronary arteries, get the freshest blood of all, and those go and supply the whole heart. They're not drawn on here though. Okay, and I think we got all this already, and yep, and out the blood goes to supply the systemic loop, every nook and cranny of your body. Okay, now what are about forces that drive blood through the heart? If you could choose just two words to describe the forces, well, one is a pressure gradient, because liquid moves from an area of, true or false, liquid moves from an area of high pressure to an area of low pressure. Yeah, it's pushed along. So there is a pressure gradient. In fact, that pressure gradient fills up about 90% of your ventricles at rest. Things change when you're exercising. But we can't completely fill the ventricles with a pressure gradient. We have to have a muscular contraction that actually fills the ventricles, that last 10%. And we have words for these two things, but that's what they are. The pressure gradient, or the passive movement of blood through the heart, you can call that diastole. And it's a period where the heart doesn't have to do anything. All the heart muscle is just relaxed and taking a really quick break before it has to contract again. Also note, there is a atrial diastole and a systole, and a ventricular diastole, right? So there's two diastoles. Now that forced muscle contraction that fills off that top 10% of the ventricles, that is systole. And also note again, there is an atrial systole and there is a ventricular systole. There's actually two systoles that can occur. Systole is almost an AKA for contraction. So make sure you know that. Key tip to remember, we said this: fluid will always flow from an area of higher pressure to an area of lower pressure. Okay, so here's a cartoon. Here's my drawings again. It's watching the 49ers game, part of it. But I guess they won. I heard they won. With a third string quarterback. Was it a good one? You know where I was? I had to go upstairs because I was making these damn slides. My wife was making too much noise. Then our daughter came over. I'm like, I'm out of here. I got to go upstairs. I can't concentrate.
I was studying for that.
So you're studying. I couldn't figure out how to record it. We have like a different recorder, and I know it can record somehow, but we never record anything. But I'll have to figure that out. But anyway, so here's our little heart with a little bit of blood drawn, and this is passive filling. And so we have higher pressure in the vena cavas. Not much higher pressure. There's only like 10 millimeters of pressure here, but there's no pressure inside the right atria. So the blood is happy to flow into the atrium, the right atrium, No problem. In fact, these valves are open, the tricuspid valves are open during this passive filling phase, and the ventricle just fills right up. But it only fills up about 90%. And when you get about 90% of this filled, the pressure is now higher here than it is in the atria and it is in the vena cava. So because the pressure has gotten a little bit too high, fluid's not going to flow into it anymore. But that's okay. We're going to contract the atria and fill it up here in a second. But let's see, kind of getting ahead of my slides. But yeah, this is an example of passive fusion. And is this occurring during systole or diastole? Diastole, right? Diastole, the heart is resting. The heart doesn't have to do anything. So it's occurring in atrial diastole. What about ventricular diastole? Is this story going on in ventricular diastole? Yeah, this is atrial and ventricular diastole when this passive filling occurs. In fact, a lot of times in board questions, you'll just see the word diastole. And when you see the word diastole, you just assume that they're talking about both of these phases. And that's not exactly true with systoles, we'll see here in a minute. But so tricuspid valve is just kind of limp, just kind of hanging out, letting the blood flow through here. Yeah, and there we go. Same thing over on this side. It's even a little higher pressure here coming back from the lungs. So blood is happy to trickle right through here, through the atria, left atria, and fill up the left ventricle to about that 90% mark again. But then the pressure gets such, because of this liquid in here, that it's higher than the pressure in the atria and it won't come in again. So we got a little problem we have to overcome there. Okay, let's see. I think we said this already. Yep. And we said this is a pressure gradient that's pushing this. And this is diastole. Passive filling, there's no power needed. And this is really quick, right? This is like just a part of a second this happens. But that's enough for the heart to get a little nap. But now, we certainly don't want to eject the heart like this. What happens if we contract these ventricles and shoot this blood out? What's our blood pressure going to be like? Crummy, right? We need these ventricles 100% filled so we have proper pressure and have proper blood volume coming out of the heart. So this is no good. So how are we going to fix this problem? We're going to do atrial systole now. So, and I didn't draw these contracted, but these contract. Both atria at the same time contract, and they literally squeeze blood until these things are just stuffed full of blood. And that's what atrial systole is. So we get that final 10% from atrial systole. Everybody good with that? Study tip, when you see the word diastole by itself, just assume that they're talking about atrial diastole and ventricular diastole, which I already said, but there it is in writing. Okay, now, so the ventricles are full. Now what are we going to do with it? Well, now let's get it out of the heart, and let's let the heart actually pump like it's supposed to. And so what happens if we open these valves up? Because right now these valves are closed. Right? The semilunar valves are closed. What would happen if we open these valves up? In this, nothing would really happen. We have kind of an equal amount of pressure. In fact, the pressure might be a little bit higher in here, and so maybe you'd get a little bit of movement, but not much will happen because the pressure here is about the same as the pressure here. We need to get this pressure way, way up. And that's what happens. Well, that's where we're going right now. We're talking about ventricular systole. And here's the other study tip. When you see the word systole all by itself, you consider it ventricular systole, because you can't have atrial systole and ventricular systole going at the same time. They're always separate. So on a board, if you see the word systole, you just assume they're talking about ventricular systole, the big systole. And you can see, and I didn't draw this very good, but you get the idea. These muscles have really squeezed down on the heart, And now that greatly raises the pressure inside the left ventricle and the right ventricle to the point it's way greater than the pressure that's in the ascending aorta in the pulmonary trunk. So because the pressure is so high now, it's happy to shoot right out these tubes and pop this valve right open. But that's not the first thing that happens. Because what does the heart sound like? Lub-dub, lub-dub, lub-dub. Where's the lub come from? Where's the lub, lub-dub, lub-dub, lub-dub? Or the S1, S2, S1, S2. Where's the S1 or the lub come from? It's the AV valves that actually close first. Remember, these valves are shut. The semilunar valves are shut, and the AV valves are open. So as the pressure builds up, the first thing that happens is these AV valves, the tricuspid and bicuspid, they slam shut really hard. So hard that you can, if you put an ear to someone's chest, you can actually hear it. This slamming of these things. We have a stethoscope, you can hear it really nicely. In fact, when you learn to examine the heart, you always listen to the S1 sound or the lub, and you listen to the dub, the S2 sound, and you listen for S3 and S4 heart sounds. You guys know what those are? Yeah, you listen for those sounds to make sure everything's working. Question? What does the S? That's a really good question. I'm not sure what it stands for. Sinus maybe, for SA node firing? I'll have to look that up. I'm not sure. Okay, but so these slam shut, and then now the pressure is really building. It's really easy to pop open these semilunar valves. Here's the question: do the semilunar valves make noise when they open because of systole? Do they? Do they when they open? No, they don't. They open quietly normally. If you can hear them, that's called an opening snap. That's a pathological condition. So these semilunar valves open quietly. How about when they close? They close loudly with a dub, like another noise, but they open quietly. So that's another important thing to know. They open quietly at the start of systole. And once they open, we have blood flying up the ascending aorta, blood flying up the pulmonary trunk here. And yeah, that's basically the cardiac cycle is what we just talked about. And after the blood is all drained out of here, I don't think I went any further than this, but what happens after the blood is drained out? Where there's no more pressure, right? So what's going to happen? The whole thing's going to repeat. After systole occurs and drains out, does it really drain out all of the heart, or is there a little residual left? There is a little residual left. Maybe we'll get into that on Wednesday, I don't know.
So you said S2 was the closing?
S2 is the closing of the semilunar valves.
S1 is it the opening of the tricuspid?
The S1 is the slamming of the AV valves.
So both closing for both?
Yeah, they're both slamming shut. Because you don't want to back, right? If this didn't, what if you had a problem with this tricuspid we'll pick on? If you had a problem with that, what would happen? You would leak, you would squirt blood, and you would fill up the atrium, which you're not trying to do. We're trying to get blood to the body, to the systemic loop and the pulmonary loop. You can't do that by going that way. So these valves, the AV valves or tricuspid, bicuspid valves, are very important that they seal correctly. And you'll see when you get into lab, it's quite an elaborate setup. They have these little parachute cords that are drawn here. Chordae tendineae they're called, and they have their own little muscle. The parachute cords are connected to the papillary muscle. It's really quite an amazing setup to see that. And I'll let the cardiology teacher get into that more. For now, we'll just talk about these valves, but it's an amazing setup. It's really set up so these can't go backwards. Because what happens if this goes backwards? What if you lose 20% of the blood in here? And now it's diastole. So this is going to fill, instead of 90%, it's going to fill up 100%. And what happens when atrial systole occurs? it's going to overstuff the heart. So now you're going to have like 110% filling of both of these, of this one, because of the regurgitation. And there's a law, if you stretch the heart muscle too much, which will happen if this is 110% filled, the heart will contract super powerfully. And that may be okay for a few minutes, but certainly you can't have that happen on every contraction. And people with tricuspid regurgitation or mitral regurgitation, their hearts are contracting super powerfully on every single beat. And what do you think that's going to do to the heart in 5 years? It's going to wreck the heart. It's going to wear the heart out, and they get heart failure. So you got to fix these valves because of that. And I'll let them get into, I don't know how deep I'm going to go into this on Wednesday. I probably won't go that deep, but that stuff's coming in your cardiac physiology class. I'll be explaining that more. But for right now, there's systole, we got the blood out. And oh yeah, so then the cycle repeats. After the blood is out, the heart's back in diastole again, and the same story. It passively fills up, the heart is resting because of that powerful contraction, and the same story repeats over and over again. So that's the cardiac cycle. Maybe on Wednesday, I'll have energy maybe to make a few more slides, just so we can more officially describe the cardiac cycle, because there's an isometric phase in there that we should talk about. But this is a good starting point for us. Pretty good with this? Think you can handle questions like this? I see heads going up and down. That's a good sign. Some fun facts about the cardiac cycle, that everything we just described has a name, and that's the cardiac cycle. During atrial systole, the ventricles are in diastole. Good study slide right here. That's true. During ventricular systole, the atria are in diastole. That's true. The atria and ventricles can't be in systole at the same time. They can both be in diastole, but they can't be in systole at the same time. That's the next point. The atria and ventricles are never in systole at the same time. Okay, diastole means that the word diastole, if you see it by itself, it means the atria and ventricles are both relaxed and taking a break, and the heart is just passively filling. Again, if you see systole all by itself, which you will on boards oftentimes, that means that the ventricles are contracting, but the atria is in diastole. So the word systole means ventricular systole by itself. Okay? Diastole equals relaxation, systole equals contraction. So make sure you understand this easy level here. I know it's probably super easy for some of you. Some of you maybe never had this before. And when they get into cardiac phys, things are going to get a lot more complicated. And it's really good to really know this stuff so you can understand the lectures. We should also say that, talk about the S1. We kind of talked about it unofficially, but let's talk about it officially. When systole occurs, the AV valves are the first ones to slam shut. And you can hear that with a stethoscope, or if you just put your ear on someone's chest, you can hear it. And that's called an S1 sound. S1 sound. When diastole first occurs, the semilunar valves slam shut. Remember, it's the start of atrial. Well, atria is already in diastole, but the start of ventricular diastole is when the semilunar valves slam shut, because there's no blood in the ventricle, or very little blood in the ventricle, and there's still blood in the ascending aorta, and therefore you got a much greater pressure difference. Okay, so the lub is the S1 sound laymen use, and the dub is the S2 heart sound. S2 again is caused at the start of diastole. We might look the next lecture, we might look at the Wiggers. You guys know what the Wiggers diagram is? Always on boards. We might just introduce you to that a little bit and then call it a quarter. Let's see some more fun facts about the valves during diastole. Oh, we said this, didn't we? During diastole, the semilunar valves are both slammed shut, and that produces the dub. And during diastole, the AV valves are both quietly open. So we said that, but I don't think I put it in writing, but there it is. So go through this, let this sink into your head. I think this is just repeats, but during systole, the AV valves are immediately slammed shut because of the pressure gradient that's created by the ventricles coming in. That produces the lub or the S1 sound. And during systole, semilunar valves are quietly pushed open. I think these are duplicate slides, because we said that a couple times. Want to break or want to finish off? Or a quick walk around break? Finish? All right, heart wall. So what is the heart wall made? That's a good, there's three. So the heart wall is made up of endocardium, myocardium, and here's where the problem comes in. So epicardium is the best answer for the outer layer. But there's some board books, including Robbins, that says pericardium. And that's not really a good outer layer of the heart. And let's look at what this pericardium is. So the pericardium is made up of three layers. From inside to out, there's a serous pericardium visceral layer, there's a serous pericardium parietal layer, and there's a fibrous pericardium. So, I'm sorry, I picked on Robbins. It was June Chiara, the chiropractic board histology book, that uses pericardium, and that's a terrible answer. It's epicardium. An AKA for epicardium is actually the serous pericardium, and this one is stuck to the myocardium of the heart. It covers the coronary vessels. It is part of the heart wall. Then there's a big gap, a gap where there's some serous fluid in, and then there's a sac around the heart. So that's part of the pericardium as well. So not a good word. And we'll kind of expand on that. That's my rant. Shame, June Chiara. Emailed them a long time ago. Did they change anything? No. But let's look at this pericardium. You're going to kind of whip through it. So the pericardium, again, has three layers. But let's look at a nice picture here. So it has a fibrous pericardium. Like if you stick a pin through the heart and it still has the sac around it, the pin will go through the fibrous pericardium. That fibrous pericardium, when you get in lab, grab the pericardium and try to stretch it, it's like steel. It's really, really strong. It doesn't allow any stretching. Stuck to the back of the pericardium is a serous membrane, just like the peritoneal. Remember the peritoneum? There's a visceral and the parietal. Exactly the same story. Stuck to the back of the fibrous pericardium is the serous pericardial. This is the parent, the parietal layer of the serous pericardium. Those two are stuck together. When you get into lab, you can feel this with your glove. It'll still be slippery because these cells make that serous type of fluid. But there's a third layer. Where's the parent is here. Where's the child? Where's the visceral pericardium? That's actually stuck to the top of the heart here. And that's the third layer of the pericardium. So make sure you know the three layers of the pericardium. Fibrous pericardium, parietal serous pericardium, visceral serous pericardium, aka epicardium. And that's the one most authors call the third outermost wall is the epicardium. The epicardium is nothing more than the visceral layer of the serous pericardium. And you can see that on the hearts, but it's super, super thin. It's like a sheet of toilet paper thick. So it's very, very thin. Okay, the other important thing to note about the pericardium is that it surrounds the base or the root of these great vessels. See, there's the ascending aorta we talked about. It's literally welded right here. If you poured water here, it wouldn't go down. It would go over the top of it. This is airtight. That's important to remember that. Same thing here with the pulmonary trunk. Same thing with the superior vena cava. The inferior vena cava doesn't follow that rule. But these big ones do. Okay, so it creates an airtight seal around the root of the great vessels. And who are the great vessels? We already said them, but there they are again. Guarantee that's coming on the test. Okay, and then same, I rant again about this. Again, the serous and the fibrous pericardium, that was the outer part. Serous, everything I just said here already. The serous pericardium has two subcomponents, has a parietal division, or you could call it a leaf, or a parietal component, or a parietal layer, whatever word you want to use, but it has two divisions. Then it has the visceral leaf. This is the one that is stuck, physically stuck to the myocardium, and is over the top. It's usually over the top of the coronary vessels. And this layer has a very important AKA, and that's called the epicardium. And here I demonstrated my amazing Photoshop skills, and I put like a little texture over this. So that's what it is. It's see-through. It's very, very thin, but you can pick at it, and you can test it, and you can stick a pin in it in anatomy. But that's, you can call it all those AKs. That's epicardium. That's the real outer layer of the heart right there. Okay, so make sure you understand that concept. The pericardial cavity is a very important concept as well. So now that we know there's a viscerum parietal serous pericardium, we can see how it creates a cavity right in between. So here's the outer layer, there's the fibrous pericardium, and we said the visceral serous pericardium is stuck, or I'm sorry, the parietal serous pericardium is stuck to it. You can't separate them. But then there's a huge gap, and then the serous pericardium visceral layer is stuck to the heart, and it leaves a cavity right here. Why is there a cavity? It's the same story as the peritoneal cavity, same story as the pleural cavity around the lungs, because these serous pericardial cells are mesothelial cells which secrete serous fluid. There's got to be somewhere for the serous fluid to go. So we all have a little bit of fluid, probably about 15 cc's or 15 milliliters of fluid around our heart right now. So that reduces friction. Your heart is covered by lungs, so you don't want any friction building up by it beating against the lungs. So it's a nice little system there. Everybody good with that? So this is the pleural cavity. So now we have a peritoneal cavity. Pleural cavity we didn't talk about, but now there's a pericardial cavity. That's really important, especially clinically, and we'll look at a problem right now. So what happens if you get an infection of your heart? You get some weird bacteria, it goes through your blood, goes through the microcirculation all over, and it gets stuck right in this cavity. And it beds into the wall of the pericardium, and it causes an inflammation. There are blood vessels in this thing, so the body's immune system can see if you have a bug stuck here. Same thing, if you have cancer cells that have wandered around the body, and they get stuck in this cavity, the body sees those cancer cells and starts attacking. You get a wicked inflammation, and we said when cells get inflamed, they either stop working or they overwork. And this is a case where they start overworking like crazy. Instead of 15 milliliters of fluid, now we got 100 milliliters of fluid in this little cavity. What's that going to do? Because the fibrous pericardium is so darn non-forgiving and non-stretchable, there's only one way to accommodate all this fluid. We have to crush the heart in. And that's what happens in this condition, and that's got a name. This is called cardiac tamponade. And it can be very, very dangerous. And this fluid can get really big. And sometimes you have to go to the ER and they drain it away. Sometimes you're okay. Sometimes it turns into scar tissue and you have a permanent block in here, and your heart just can't beat correctly. And they have to take the pericardium out, which they can do. You don't need a pericardium to live. You'll need a pacemaker after that procedure, but they can get rid of the pericardium. But this is called cardiac tamponade, and it's caused from any type of fluid or any type of substance growing in here, whether it be cancer cells, bacteria-induced overproduction of this serous fluid. Whatever it is, if it crushes the heart because it's in the pericardial cavity, it's called cardiac tamponade. There's some idiopathic cardiac tamponade that kind of once in a blue moon comes in the emergency department, and they don't know what causes it. But they found some people are allergic to cigarette smoke particles, and the cigarette smoke particles can travel through the bloodstream and get stuck in the pericardial cavity here. The body's immune system spies them there and attacks them, and it creates this scenario right here. So, but anytime there's stuff in here and it's crushing the heart, that's called cardiac tamponade. Okay, everything I said. So, and not to mention it hurts. They'll go into the emergency room thinking they have a heart attack, but a little soft tissue film can show that the heart is swollen up and has fluid in it. But it's interesting how this affects the heart too. When the heart contracts, I think I said this, it's not like making a bicep where your bicep gets bigger. The heart actually gets skinnier and longer. And the point of the heart goes up and it pokes you right here, kind of by the nipple area. It pokes you. So about, if you guys all lay down on a bench and we all looked at your chest, about 33% of you, we'd be able to see a little pulsation right kind of by the nipple there. And that's called the apical impulse. And that's from the heart getting skinny and raising up and poking that part of the rib cage. So what happens when the heart is being strangled by all this fluid, since the heart doesn't do a big bicep, it's not going to affect that part of it. It's not going to affect systole. But what happens is it affects diastole. It doesn't allow for filling of the heart because the heart is always kind of clamped down like this, so you can't fill and stretch the heart out. So it's a problem with filling, and it's a problem if you don't fill the ventricles properly, you have a decrease of blood coming out of the heart. And I do want you to know these words. The blood that comes out of the heart is called stroke volume. So cardiac tamponade can reduce stroke volume. Another term where blood coming out of the heart is cardiac output, is even a more general term. Stroke volume, cardiac output. And you'll learn there's like little formulas that you get in physiology. We'll talk about that, but you should know what stroke volume. That is the amount of blood coming out of the heart. If you have cardiac tamponade, you're going to have decreased stroke volume. What's that going to do to your blood pressure, you think? If you have decreased blood, yep, there goes your blood pressure down. And so the same story, you can have decreased blood pressure. That can lead to not properly perfusing your organs. Your brain doesn't get enough oxygen, your liver, you get a lack of perfusion, and you slip into shock. And this is because it's a problem with the heart. It's called cardiogenic shock, and I do want you to know that word as well. You'll learn there's 7 types of shock, but I'll be happy if you just learn one. Cardiogenic shock means there's a problem with the heart, and the heart, for whatever the reason, the heart is not pumping enough blood out. And if you don't have enough blood coming out of your heart, there goes your blood pressure, there goes your perfusion to your body, and that's what shock is. And your body and your brain are not being properly perfused, and everything starts shutting down, and you can die from that. Everybody good with that? All right, let's move away from the pericardium now. This is a very simple layer, and it's a big layer. This is the myocardium, and this is filled with muscle. The myocardium is deep to the fibrous, or is deep to the epicardium, I'm just going to call it, or you could call it the serous pericardium, parietal layer, or no, visceral layer. I know it is epicardium, but it's deep to that. It's very powerful. This is what causes the chambers to squeeze down and squirt blood out of it. You'll learn when you get into anatomy, there's a layer here called trabeculae carne. So the inner surface of the heart looks like kind of carne meat. It's got a really weird look to it. But that's it right there. It's filled with cardiac muscle. And remember from your cell-phys, there's only 3 types of muscle in the body, right? There's cardiac muscle, smooth muscle, and skeletal muscle. So this is one of those muscles. Oh, that's 3 things. Wouldn't that make a nice question? Myocardium, so yep, here's the cells kind of hang out in big bundles right here. There's the endomysium, that's almost like a ground substance that they sit in and live in. Each one of these bundles is surrounded by a perimysium. These are the actual cardiac muscle fibers right here. Just some kind of simple histology stuff. Here's just another view, cardiac muscles. I'm not going to go much deeper in that into it. Now the people who didn't show up today in class, they'll go, oh my God, we got to know all that stuff? No, you don't have to know that stuff. But how are they going to know that? So they'll be studying that stuff. Let's see. Then the fibers are kind of in a spiral type pattern, as we just saw. And again, when the heart contracts, you get a decreased diameter of the heart. I always ask that question because you immediately think muscle contracts, it gets bigger. This is not true. The diameter of the heart actually decreases. It gets longer though. It elongates, but it gets thinner in diameter. And this is why any type of problem, we didn't talk about restrictive pericarditis, but that's just like tamponade, only you get scar tissue inside that cavity around the heart and it strangles the heart that way. Anytime you get a strangling of the heart, that decreases the ventricle filling because of the strangling. That's going to decrease stroke volume, that's going to decrease blood pressure, that's going to decrease organ. What's perfusion mean again? Oxygenation. Perfusion is oxygenation. And that's going to kick you into cardiogenic shock. And if you don't get treated, you will die from that. Kind of everything we said already. Let's see. And this is what I was trying to say about a contraction of the heart makes it skinny and long, but it does bend up, and the apex or the point of the heart stabs the anterior chest wall, and it makes something called the apical impulse that's visible in about 33% of humans. You guys haven't had CVP yet, right? Okay. You definitely want to know this for boards. They love the apical impulse, this little pulse, even though you can't see it in everybody, because that's a really good judge of the size of the left ventricle. It's much more accurate than percussion. It's got a sensitivity specificity in the 90 percentile if you can find this apical impulse. Question?
Why do we take the mitral valve pulse there? Or like when we have stethoscope, we're listening to the heart sounds? Because if we take it on the ventricular line of the intercostal?
When you auscultate the heart, there's actually 6 auscultation areas that you can auscultate for.
Is there a reason why mitral is right there, right where the apical pulse is?
It's not where the physical mitral valve is, it's where the mitral valve refers, and where the mitral valve refers sound is the mitral area, if that makes sense. Yeah, auscultation. The auscultation points, have you guys learned that already?
Yeah, I think that's fine.
And did they go over the APET monkey area, all pigs eat too much? Aortic pulmonic Erb's point?
We learned that.
Tricuspid APET monkey? Yeah, APET monkey. Realize that those locations have been tested in the lab 1 billion times, and that's where the valves refer sound. It's not the physical location of the valves. It's not even close to some of them. Okay, so apical impulse, where is it? I'm going to ask you a question. I'm warning you right now. It is, you know where the midclavicular line is? Midclavicular line, 5th intercostal space. It's just inside of that point. It's usually where the nipple is, but they say don't use nipple locations because they can be quite variable. But it's usually around where that nipple is. In females, when you get in that class, they have a bra on, it's right against that underwire. In the midclavicular line, right up against that underwire is where the apical impulse will be. Okay, let's see. It should never, ever, ever be bigger. If you can palpate it or see it, if you can get your finger on it, it should never, ever, ever be bigger than a quarter, right? In other words, it shouldn't be bigger than 1 intercostal space. Well, I get pictures. I'll show you here in a second. If it is, it's very accurate. If you can palpate it in 2 intercostal spaces, it's probably over a 90% chance that patient has left ventricular hypertrophy, probably from hypertension that hasn't been treated. That'll kill you. It's really good at detecting that. I have no idea. My screen looks good. Wow. I think we're almost done. I think we are done, huh?